Hello and welcome to the webinar on CEREC and digital dentistry and how it's benefited me, how it's benefited my patients, and most importantly, how I hope it can benefit you and your patients as well. This is called Go Digital and Never Look Back because, quite frankly, since I've become a CEREC dentist, I really embraced digital dentistry in a number of other facets as well. And it just allows workflow. It allows joined up dentistry to be done such a much more predictable way. And it's given me so much more confidence to do, I suppose, bigger dentistry, better dentistry. I'm really happy with the results. So I'm going to encourage you to have a look at what's on offer, and then maybe it'll do for you too. So we want to know why. Well, I want to tell you a little bit about my journey anyway. So I'm going to talk to you about why I got CEREC, what my journey was, and most importantly, the benefits to my practice, my patients, to me, and then, as mentioned, most importantly, I suppose, to you. So who am I? Why should you listen to me? My name is Alif. I am the principal dentist at Oakdale Dental in Leicester. This is my surgery, Oak One. And I'm really passionate about education, actually. Ever since I was little, I've been a bit of a geek, and certainly at dental school, I was a big geek. My friends were few and far between until it came to exam time, in which case they always wanted to find me and ask me, what's this, what's that, how do we revise? Actually, maybe I just did. Some good lads. But I've carried on that passion, and I've been on loads and loads of courses, a bit of a course junkie. And I've transferred that passion for learning into a passion for teaching as well. So I've become the director for dental tubules in Leicester, and also for ITI as well. Now, both of these are really big educational groups, one of which is to do with general dentistry, and one of them is more implant focused. But I'm really proud of that role because there wasn't as much education in Leicester before. So it was nice that I was able to create something and do that for practice. And since then, I've been lecturing on loads and loads of topics, but the ones that I'm most interested in are digital dentistry, of course, and implant dentistry as well. And I wrote a book called The Smiling Dentist. That was about 4 or 5 years ago. I thought it'd be interesting to do a book that was for the benefit of patients, so educating them in a way that was accessible to them. So I'll talk a little bit more about that in a second. I was really lucky that with a bit of what I was doing, in the chair and also extracurricularly, I was voted Best Young Dentist in 2016, which is great. Best is lovely, but I tell you what, young. Now that's what I was celebrating. So we're going to take our journey into what we're doing in the practice here. So this is my practice here, Oakdale Dental. This is our waiting area here. And I really want my patients to feel like they've come home when they come and see us. I want it actually to be a positive experience. Positive is difficult in dentistry. If I get neutral, I'm generally quite happy, which is always good. But I want my patients to feel like they've been well looked after. Now, the reason I make this point is because we can invest a lot in dentistry. As dentists, we can invest in the best materials, best impression material, best retraction cord, all of these things. And patients don't really understand, they don't get the tangible benefit for that. But if you invest in something like CEREC, for instance, my experience has been that they can absolutely see what's going on. They can see the difference. The tangible benefits to them are that they don't have to wait 2 weeks for a crown anymore. They don't have to have impressions anymore. They're super happy. So it's worth us being able to do something that improves the standard of the dentistry we can provide, but also allows our patients to see what we're doing for them. That's why when I took over Oakdale Dental, one of the first things I did was transform the waiting area. Because I know, obviously, we've done the surgery subsequently, but I felt like the waiting area would have the biggest impact on our patients in terms of their journey, because that's where they wait. It's probably where they're going to notice the details and notice the change most. And I think the feedback that we got was really nice, actually, when we did that, because I think patients thought, well, this is great, we've got a new principal who's coming, and he cares. Being that principal can be tough. To have high standards and to maintain them means that sometimes the team are less than happy when you're badgering them all the time. So that's me, obviously, there on the right, and that's the chap I bought the practice of. Look, he's strangling me, everyone's laughing. Look at them smiling. It makes me even more interested that up in the top right, that's my wife. Look how satisfied she is. Maybe I'm the same at home as well. And we were lucky enough to be written up in private dentistry as well, and just showed a little bit of the changes that we'd made when we were transforming our practice and what we went from and how it ended up. As dentists, all eyes are on you, whether it be principal, where you're the leader of the practice, or associate dentist, where you're leader of your surgery. That team there that you can see mainly on the back row there, they're not really in it for the money. To be honest, dental nurses don't get paid a huge amount. They're generally in it for the vocation. They're in it for the love of doing what they do. And if you can be the guy who is seen to take care of your patients well and seen to invest in their journey and their, I suppose, their whole experience at the practice, then your team get on board really quickly. It's a really nice thing. They can be pretty unnerving at the top. You can tell by those chins. And you can see that that's Ocon, that's where we are right now. So how did it all start? So really, once upon a time, I was just a normal average dentist. I was just treating patients, doing composites and scale polishes and all sorts. I was doing everything in-house. But I always liked doing crowns, to be fair. That was like one of my favorite things to do. But I used to go on courses, as I said. I'd go and I'd listen to these big guys presenting these big cases with implants and all sorts of stuff. And I wanted to be one of them. I wanted to be able to show my work to other people and be proud of what I did. I knew if I was going to do implants, because I'm not really, I'm not a big surgeon. I wasn't really doing much surgery at all, actually. I would always refer it out. I knew that I'd need some help, from placing implants and stuff. So I'd seen this stuff about guided implant surgery. And I saw that that really helps you to get very predictable results. So if you're faffing around with the surgery and raising the flap, which to be fair at the start I always was, it's getting a little bit better now, thank God. But I thought it'd be really good to then not have the stress of where do I start my osteotomy and all the rest of it. So I thought I need guided implant surgery. And also I bought this practice, Oakdale Dental, and it's an implant practice. So not being able to do surgery was, I don't know, maybe a challenge, but we managed to overcome it. So really, I bought CEREC for implants. But I really wanted excellence in dentistry. And as we've touched on, I wanted a wow patient experience, enjoy what I do, and really do the education well. So the nice thing about CEREC is it's not just back teeth restoration for single tooth. It mimics your general dentistry learning curve, I guess, because you start off with simple stuff, single tooth dentistry, but then it allows you to incorporate digital planning into smile design. Okay, it allows you to take face scans and then incorporate that into your planning so you get midlines right and the like. Okay, and it allows you to do digital wax ups and then use biocopies so that you can have a provisional set made for your patient. Tell them, do you like this? Sign it off, and then you can copy and paste it because it's a digital workflow. Sometimes it's really challenging when you have worked really hard to do a rehab. You've got it really nice in the provisional stage. Patient loves it. Bite is good. Everything is nice. And then you ask your technicians to copy it, and it's difficult. In an analog fashion, it's difficult. There will be some discrepancies, and that's a real challenge. And digitally, it doesn't happen that often, so it's brilliant. That's a little bit about DSD. So you can see here we've got a patient who came to see me who was unhappy with their smile. They didn't know what or why there was a problem. So I put on a smile frame. So this is just a smile frame which shows the red proportions. Okay, they're a little bit like the golden proportions, recurring aesthetic dental proportions. And when you do that, the power is that your patient starts to diagnose their own smile. They can see the deficiencies. So what you can see here is that So the patient actually said to me, look, are my teeth short there? Do I need to lengthen them? Actually, as it goes, they probably are. But then also, it picked up a conversation point about the gum up on that top left-hand side. And we're thinking, well, actually, do we need to do a bit of gum work if we want the ideal smile? So at least I was able to have that conversation beforehand. Now, in this particular instance, I've got a periodontist at the practice, but in this particular instance, the patient was not up for having periosurgery done, crown lengthening or whatever. So at least I was able to manage his expectations. So he knew that he's paid all this money for a beautiful smile, and he is not going to hold me to ransom at the end when it's not perfect, because I can't correct that gingival architecture with veneers on itself. So he understands right from day one. So it's a very easy and nice way of having a conversation. So, as mentioned, I wanted guided surgery. That was what drove this whole thing. In order to have guided surgery, certainly the Sirona workflow, you need CEREC. CEREC on the left comes in two parts. There's the acquisition unit that you can see there, that's like a cart with a computer, and the camera, you can see just enlarged there. And that camera is what scans the teeth and allows you to create these 3D models, virtual models. And then the other part of it is a milling unit. So once you scan the teeth, the software allows you to design a crown, and then that design can be transferred to the milling chamber, and then it can be milled out. So you can do same-day dentistry. It's beautiful. It's really nice. On the right there, we've got the CT scanner, and I had that already in the practice when I bought it, because I bought it from a specialist oral surgeon who used to place loads of implants and needed a CT, and he had the Sirona one, so it kind of made sense. So I already had one of those to buy one of these and one of these, which I've put in the waiting room, and that's now become a bit of a conversation piece. You need one of these cabinets here because the cover that goes over it is like an acoustic hood. Otherwise, it's a bit loud. You know, when the receptionists are on the phone, they complain a bit. But with that on, it's nice and quiet. But patients are able to see it, and they get excited by it, and they ask, "What's going on? What is this about?" And it's really nice to be able to explain to your patients what you've been doing, what you've brought to the practice, and most importantly, how it's going to benefit them. So now my patients do benefit from crowns in a day. They don't have to have impressions anymore. The fit really, really is good, honestly. It's something else. It's better than anything I've ever got from the lab. And the aesthetics are good as well. The aesthetics are really nice because you're making all porcelain restorations by default. And if you're making the jump from using porcelain bonded, which is a bit dead and lifeless, to using all porcelain restorations, it's just a different world. The reason is that obviously there's a color, isn't it? There's a chrome with that that teeth output. But there is also it's made up of a crystalline structure, and what that crystalline structure does is it plays with light. Like the light will come in, and then some of it will be reflected out. Normally that's the bluey spectrum, and some of it will be absorbed and then reflected back into the mouth. So if you took a photo standing on the tongue, looking at a tooth, it would look reddy. And so the nice thing about all porcelain restorations is because they are made of a crystalline structure similar to tooth, they'll play with light in a very similar way. So you end up getting, much nicer aesthetics without much of a problem. The problem when you have maybe zirconia and metal, in fact, as time has gone on, I think of zirconia as metal. I know it's not, it's a porcelain, of course, but it's the way that you cement it rather than bonding it, the way that you prep for it, it's much more like a metal than you would think of as a Emax or Empress or something like that. But because it's also, it doesn't allow light through in the same way that metal does, the way that it interacts with light is completely different. So very nice for posterior restorations because you don't get that light interaction as much in the back of the mouth because it's big shadows. But at the front of the mouth, something that's also perfect, beautiful. Because of this, by the way, most patients say, yeah, I want the crown because we're overcoming some of the things that would have stopped them from having it in the past. So I feel great because I feel like I'm going to give them a good, long-lasting restoration that's strong, and they're going to be happy with it, which is ultimately what it's all about, and so do I, long term. So this is what we were talking a little bit about before, that we want patients to be happy. Okay, we want them to be able to see what you're doing as a dentist to try and not only meet their expectations, but to exceed them as well. And if we want people to recommend us as a practice over the person down the road, we can't just be okay. In fact, we can't just be good. We have to be outstanding. We have to really offer something different. And with all the service stuff and all the little points, that's great. But if you can give them a wow, like CEREC, then you're laughing, honestly. And if you're able to give them wow dentistry, which is easy dentistry, painless, it works, when they come back next time, say, oh, it's great, I forgot I had it, and all the rest of them, they gain confidence very quickly. Be consciously aware of your brand, because what your brand is what people are saying about you when you're not there. That's what your brand is. It's not your letterhead, your marketing or anything. What you do with your letterhead and your logo and your marketing leaflets is you either do things that will enhance the brand that you want people to think of you as, excuse me, or you detract from it. So if you're trying to make out that you're a really good dentist, trustworthy, everything's good, you're premium, you're the best, and then you have like a leaflet that's on A4 normal paper and it's like done with Word or something in Comic Sans, then people are going to think, oh my God, really, what's going on here? So that's where branding comes in, but your brand really is what people think of you. Making an investment in your patient's experience is a great way to show them, or be consciously take control of the brand and tell them this is what I stand for. So we'll go into this very briefly, but impressions of fraud problems, we get material distortion, tray bending, bone flexing as well, especially with mandibular impressions. So being able to scan rather than take impressions is really good. Scanning does have its limitations, I know. For full arches, which have no teeth, it's very difficult for it to be stitched correctly now. But dentate full scan, getting much better now, I found that a nice tip on the times I do have to make impressions are to try and use a two-stage technique. So you use putty first, push and pull, all the rest of it, everything's going to distort. But then you take it out, let it relax, the bone will relax, and then put your light bodied in afterwards, and then very gently seat that home so that you're not incorporating those distortions again. And that seems to work relatively well. I say that, I've got a bridge at the moment, so I don't think it always works, and that's when I have to do that. Yeah, it's funny that actually, because now I've got so used to CEREC and everything just fitting, and then if it doesn't fit, just mill a new one, it takes me another 10-15 minutes. That when I have got a crown or a bridge that comes back from the lab for any reason, I'm like a bit worried, and I get anxious now. And if it doesn't fit, I'm just a bit sore head. Yeah, that's an insight into my life. So my learning journey with CEREC, because I was working up to doing this implant guided stuff, was learning to restore posterior teeth. Yeah, so I could get the hang of scanning well, designing well, and milling. And then, importantly, I had to learn how to prep for all porcelain restorations, because I wasn't doing many. I was doing mainly porcelain bonded crowns. So the considerations for design are different. Rather than having these Schillingberg preps with resistance retention form, if we're doing a bonded porcelain restoration, then what we really need to do is obviously dismantle the tooth. You're able to take all the restorative material out of the caries. That's basic anyway. Now, this is not a rule, but it's a guideline, and something I like to do more and more is I don't have cores as often as you might think. There are obviously some instances where you need to build things, but on the whole, I try and have as few interfaces as possible. I would like to have tooth, the bonding agent, and then the restoration. I think that makes for a shorter chain, because at the end of the day, your restoration will only be as strong as its weakest link. So if you've got the bonding to the restorative material, then the restorative material bond to the cement, and then the cement to the restoration, there's more potential for error there. So that's my rationale in doing that. And the nice thing about CEREC is you can pretty much make any shape. Okay, now obviously it's got to fulfill certain criteria, which we'll go into. But if you have that shape, then you're basically able to scan and make like a jigsaw piece that will just fit on whatever shape it is. It doesn't have to be this crown, uniform crown, all the way so that you're making a helmet that goes onto the tooth. It can be anything that you're just going to bond on. Because it's porcelain, we don't want to have any thin margins. We would like to ideally have a deep chamfer, because a deep chamfer is nice and rounded. Ideally not shoulder, because shoulder obviously gives you this step, and that can then create stress propagation in an unfavorable way afterwards. But yeah, having a deep margin reduces the incidence of the margin chipping, which is really frustrating. If you've set it to mill and it comes back and you see it, and you say, oh, crap, what's this? It doesn't fit properly. So you need that bulk, protect that bulk. And then you need it to be a smooth prep all the way around. Any sharp or jagged bits, you're likely over time with cyclic loading and chewing, if you've got a little bit that's sticking up, then as you load it, you can get fracture propagation from that sharp bit here going up towards the biting surface, and then your restoration fractures and fails. So smooth is ideal. And this is basic, as what I will do after I prep a tooth and I'm happy, then I'll just run my film over it and I'll just try and see if there are any sharp bits and smooth enough. Okay, so what you'll find is you'll do more restorations where you will maybe not be doing full crowns, but you'll be doing inlays and onlays. So I wanted to present a little bit about when to cover cusps and when it should be an inlay, when it should be an onlay. This is lovely work by a chap called Ron Jackson, who's an American dentist. He does lots of composite stuff, lots of direct and indirect, and he also does porcelain as well, but the principles are the same. So what you can see on the left there is scenario where you would cover cusps. Okay, on the left of the left picture is a wall which is thin. Okay, it's less than 1 millimeter thin. Now that means you're less likely to have a favorable height to width ratio. But I want you to consider the height to width ratio, not just the width of the cusp. So sometimes you have a really, really deep box and it's over 1 millimeter, but you can see it still looks spindly, it still looks weak. In my opinion, I would cover that. And sometimes you have maybe even less than 1 millimeter, but it's a really, really short stump of a cusp because the box floor is not that deep. So conversely, I would probably allow that to stay. On the other side here, you've got undercut. Now the undercut there, what it's showing is that you've got an undercut and coronal to the undercut is enamel. So that means that enamel there is unsupported, so you would need to cover that. On the other side, what you've got there is you've got a cusp which is fatter, okay? Chunky is greater than 1 millimeter, but please bear in mind the height to width ratio again. And then what you've got is undercuts where there is dentine coronal to the undercut, both of those. So that can be filled out. You can either fill them with filling material, or in my opinion, I prefer just to scan it, allow the CEREC to go in. It will never try to go into the undercuts. It wouldn't do that, but it will have passive fit, and then that can be filled up with resin cement. And generally, it would always be resin cement that I bond these porcelain restorations with. So let me try and put some of those principles together in this presentation case here. So this was a patient who had fractured that buccal cusp on the 5, and then I showed him this photo and I said, look, that 6 is not looking great. Would you like me to do both? It'll be one injection and all the rest of it. They said, yeah, let's just do both because it's done there. So I'm sorry about that first picture, but these are intraoral camera photos now. So what we can see there is the pre-op at the top, and then all I've done for the second picture is to very quickly remove the amalgam. I've just chopped it out so you can see all the crap is still in there. This should not take long to do, okay? It's about just undermining where the undercuts are, and then you will find that the filling will just jump out basically. You don't need to be taking every single bit of amalgam out. This is really time consuming. Once you got to that picture at the bottom, that's when you can do your analysis for cuspal coverage. In my opinion, all of those need to be covered. So I'm covering them all. And I didn't say before actually, that when I'm not sure, then I cover. Because I'd much rather engineer the restoration well, because I want it to last a long time. Now I know there's lots and lots about minimally invasive dentistry, and I agree. I don't want to be willy-nilly cutting teeth for no reason. But if you think about it, if you spared a few enamel prisms, but then it's a weak cusp and it fractures, then you've condemned your patient to another intervention. And how minimally invasive is that? So I'm all for over-engineering. So I'd much rather cover when I'm not sure. Okay, so what I've done between the photo at the bottom there and, oops, sorry, this photo at the top, the two photos at the top there, is I've reduced the cusp height and I've just cleaned the boxes out a little bit so I can make an even better assessment. And eagle-eyed among you on the top right-hand side picture, you'll see that there's caries distally on the 6th. So when I noticed that, I started to think a little bit about where I'm going to put my margin. And I decided, partly for aesthetic reasons, partly for ease, honestly, of providing restoration, that I was going to prep a margin to make it a crown on the 5. And I accept that we could bond a restoration on the above photo, but I find that with experience, I know what I'm going to get a better result with. And then on the left-hand side, there's not a crown, it's an onlay, but I've put a buccal margin in, and in fact, I've extended that margin all the way around, because when I put the buccal margin in, by the time I've removed the caries distally, I knew it would allow me to make a much more predictable restoration if I just gave myself a little plate of shampoo as well. So that's how I designed those restorations, or the preps rather. And all I've done between that photo at the bottom there and this photo here is I've just run my thumb over it. So you can see this is by no means a Schillingburg prep. It's nothing like that. And it's also not classical textbook like all porcelain bonded prep, because we had a restoration in there. And so what I've tried to do is utilize the principles of both to try and get me some mechanical retention, but then also prep it well so that I'm not invading any of those principles of providing an all porcelain restoration as well. So that makes sense. You can see nice big margin, yeah, a thick margin. So I'm giving the marginal integrity, so I'm not losing material thickness in the wrong place. I've given more material thickness by not adding a core. There's undulations in there, which I like. I like to have a little bit of sort of this mechanical retention. Nothing sharp as mentioned, but just undulations I'm happy with. And definitely enough space has been created to give myself material thickness, not just at the margin, but everywhere else as well. Okay, so learning to bond the all porcelain restorations was important as well. What we need to do is treat the porcelain properly. So you need to use hydrofluoric acid etch. So that's the red etch. It's nasty stuff though, so you have to be a bit careful with it, especially when nurses are handling it. Then once you've etched the surface of that, then you can use silane, and then that gives you the ideal bond in that restoration on the fit surface of the restoration. And then, as we touched on before, I always like to use resin-based cement. Resin allows the internal fractures, of which there will always be, whether it's milled or pressed or whatever, there'll be small internal fractures of porcelain on the fit surface. And what the resin will do will fill those and heal them. Whereas if we use a glass ornament cement, then because it's an acid-base reaction, you'll find that it will get into that crack and it will allow it to propagate. It's a little bit like rock, you know, that freeze-thaw kind of thing that happens. So it's more likely to cause failure later. So I always recommend resin cement. So, I'm sorry, when it's been formatted, I think that slide's not come out quite right. But there are different materials that you can use with CEREC. And really, they fall into one of 4 categories. What I've put here are the 3 permanent restorations. So at the top there are hybrid restorations, which are a little bit like composite, but stronger. They've got more ceramic particles in them. And they're very nice, actually. They're not as strong as some of the porcelains, but the way that they work alongside the tooth is very nice. A similar flexural strength and also similar wear properties. So it's actually kinder to the opposing dentition. But also, if it's a big restoration, you want, especially an inlay or an onlay, you want it to flex in a similar way to the tooth so that you don't have this differential flexion, which can then cause fractures, whether it be with the restoration or more likely with the tooth that's left. Next down is the felspathic or the lucite base. If I'm honest with you, that's probably my workhorse. I generally use the Empress multi blocks. So you can get blocks which are a single color all the way through, but you can also get blocks which have different, like a color gradation that goes through. And those are just a little bit more pretty because they mimic real life teeth, with the bit near the cervical margin, which is very low value, but high chromaticity. So you can see, you know, thin enamel and you see more of the dentine through. You've got the mid body, which is a bit of both, high, you know, value, mid value, and with chroma. And then the enamel bit at the top, where the enamel from the occlusal surface or a palatal surface joins the enamel from the buccal surface, and that's very high value, very low chroma. So these blocks have that programmed in. It's very neat as well. You can move the restoration in the blocks. If you've got a young patient with a lot of enamel, you can move it a little bit higher, so it's more biased into that area. If you've got a much older patient, move it lower, and try to take advantage of that block as much as you can. The last global group here are the lithium type ones. These are like lithium disilicates or lithium with zirconia. And a couple of the big players are Emax, which is an ivoclar one, which is very nice. And in fact, the case I'm showing you is the Emax one. But having said that, I don't use Emax as much now as I used to. I probably use Empress a lot more, and also the hybrid blocks a little bit more as well. Now, my thinking on this is that, you know, a lot of people, they get all about the megapascals. Yeah? They're all about strength, 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 which I understand. I don't want to put weak stuff in and have a break. But there is a point at which you don't need any more strength, because long before that restoration cracks, something else is going to fail. It's either going to be the tooth or the periodontal ligament or the TMJs or the muscle. Something else is going to cause you problem. And so I'd much rather have something that's harmonious with the system, because I think that gives our patient a much better long-term lot, really. That's what we want to provide for them. And so Emax I'll show, and then there's another one called Celtra Duo, which is a Dentsply Sirona one. It's new, it's coming out soon. And that is the first block that can be used either straight out of the mill or in the furnace. Now, the hybrid blocks at the top and the feldspar blocks, you don't need to put in the furnace. So it's a much quicker workflow. You can do a crown in about an hour. Whereas with the lithium ones, traditionally, because it's so hard and scratch resistant, if they gave it to you in its finished state, it would blunt your burrs really, really quickly. So they provide it to us in a purple phase, especially Emax, that's a purple block, and that's the pre-crystallized phase. And the pre-crystallized phase is much softer, so you can mill it, but then you have to put it into an oven and fire it. So the point I was going to make is Celtra Duo you can either use in the oven or not, so it gives you a bit more flexibility. Obviously, the strength does go up if you put it in the oven. So what we've got here is the try-in of that purple phase, Emax. You can see on the left there, those are the screws. Those will have been the bit that sort of held onto the block last, and you just polish that off in the mouth, preferably in the purple phase. And then what you have to do, because lithium blocks, you can't get that 3 layers heterochromaticity banked into the block in the same way that you can with Empress and with the hybrids. Then what you need to do is you have to add a little bit of character to it, otherwise it looks really dead. It just looks horrible, it's a wooden color. So you can see there's a little palette there, and what I've got on there, the white is glaze, so you glaze the whole restoration, and then I will put that browny one on the cervical edge, near the gum, so that will give you your high chroma, low value edge. And then the blue there, if you just put a little bit very gently on the cusp tips, it gives you that bright high value bit. And if you want to, you can put mahogany, which is on the top left there, into the fissures, and that allows you just to give a little bit of fissure staining. There you go. Okay, and so that's how it looks when you have put when you've stained it, and then on the right is how that translates to real life when it comes out of the oven. So you can probably see more on the premolar there, how the brown around the neck has been translated, and you can probably see the warmth in the fissures there. And that's the final result. So you can see this patient's come in for same-day dentistry, and we've been able to provide him something that is quite harmonious with his smile. I'm sorry, I know that it haunts me, this picture, I'll present it a bit, but that cement around the 6, which I didn't clean off there. There you go. But the rest of it's nice. I'm happy. Look at the color match, the gradation of color throughout. It's nice, and he was over the moon, to be honest. Doesn't always go according to plan. This was a proposal I had the other day. So I managed to. So when I say proposal, what happens is you would scan the patient, and then you would ask the CEREC to design something, and then normally it looks like a tooth. Honestly, about 90–95% of the time, it looks like a tooth. But then sometimes it kicks up this. So I thought, great, doesn't matter. I know exactly what I'm going to fix. And then it gave me this. What? Are you kidding me? I thought I was supposed to be good at CEREC. But anyway, we managed to fix it in the end. So it's always worth knowing how, with experience, you learn what does what will affect another thing, and then you're able to fix it. And we managed to get it right in the end. Sometimes you think maybe the prep was rubbish, but this was quite a nice prep. I don't mind saying this is my associate's prep anyway, so it wasn't my work. But look, CEREC managed to give us this. So it does happen. We managed to fix it. It was a really easy thing to do, but my associate joked with me. He said that perhaps this is CEREC trying to help us to make more money. You could fit that crown and then offer ortho to the patient so that you can correct it afterwards. So one thing that I really like about CEREC is that it has a mode in it called copy and mirror. So what you can do is use that to do this dreaded single central incisor. You can take information about how the upper right one, natural tooth, looks, and then transfer that to make the upper left one look better. And this was a case where I saw a patient. Now, I did two things in this. I used the copy and mirror so that the technician had more information, but then also, as I allude to, I use a technician as well, because there is so much I can do with CEREC. And if I'm really honest with you, I know I bought it for implant, but I also bought it with the thing that I spent all this money on CEREC. I need to cut the lab out. By cutting the lab out, I'll be able to get my return on investment. But I have to implore you to not do that, because there are some things technicians do which are amazing and I can't do. And if I wanted to commit myself to the journey of learning how to, it would take a lot of time, a lot of effort, and I'm better remunerated if I just stick to dentistry. I had a really good example of this. I had a patient who came in for 2 days and we did a full mouth for him. And on the first day, I did all of his anterior teeth. And I asked my technician, Lino Adolf, a well-known technician, to do the designs for me. So I scanned the mouth and I sent the designs to him through the internet. And then he sent the scans to him. Then he designed the crowns rather than relying on the CEREC software to do it. Because if I'm honest with you, CEREC software does amazing posterior teeth. I hardly ever have to change them. But anterior teeth, sometimes I have to do a little bit of work with. Much rather my technician was there. In the time it took him to design those 6 crowns and then send them back to me, it was an easy process, because then I just have to mill them one by one. So it's still same day. I managed to place an implant. Now, if you think about what I'm going to pay him to do those designs for me versus how much I've just earned by doing an implant, it took exactly the same amount of time. You can see why I've developed this ethos of just sticking to what I'm good at and delegating the bits that I'm not so good at away. If you keep it all in-house, you become that jack of all trades, and it's a bit difficult to master everything. That's my experience anyway. But anyway, so this is how he looked before. So we can see, not massively aesthetic. One of the things that is a bugbear, you can see it really nicely on that photo on the right, is the luster is completely wrong with that crown. So you can see it's nicely polished teeth, but that is dull. And it just jumps out at you, because you can notice that probably more so than anything else, I think. Now, the reason I say this is because the goal, isn't it, is to put a restoration into a patient's mouth and for it to just disappear. That's when you know, yes, that's a good day. And people's teeth naturally are different colors. They are different colors. So if you get the shade a little bit wrong, it's okay. It's not the end of the world. But patients brush their teeth all as a set. They eat and chew all as a set. And so the wear pattern on teeth is uniform throughout the mouth. So if the luster is shiny, for example, as in this case, then you can't put a restoration in that's dull. If you do that, you're in trouble. It will sing or jump out at any casual observer. So as we mentioned, this is what happens if we bring the lab into it again. So what we did here was I scanned and then I sent it to my lab and I asked them to do a custom shade as well. And then they printed this model. Now, model printing is sexy and it's amazing and all the rest of it, but actually you don't always need it. There are certain times where you do. So out of the CEREC will come a full contoured crown normally. So you can do staining and glazing, you can do that in-house. the contours of that crown will be correct. You don't have to drill anything away. You don't have to add anything back. So there's no benefit in printing a model to check fit. The reason I make that point is because imagine if, God forbid, the scan is wrong. Yeah? If the scan is not quite accurate, then not only will your crown not fit properly, but your model will not fit either. The model will not be right. So the crown is likely to fit on the model, but it's still crap. It's still not going to fit in the mouth. So you haven't gained anything by printing the model just to verify fit. Nothing at all. The time you do need a model is, say you wanted to do cutback and layer on that front crown. Then because you're going to be cutting the incisal edge away, or the technician more likely, you're cutting the incisal edge away, and then layering porcelain for beautiful aesthetics, incisal edge and all the rest of it, then they need to be able to verify back their human position that they've given for the incisal edge. And that's when you need a model. Okay, so just be critical about when your technician says, oh, do you want a model for that one? Don't just pay them the money and have it done, because you don't always need it. Excuse me. So this is how it finished. So I'm sorry about that cement margin again. It's crap, I don't know. I've got to take, I've got to be more patient when I take my photos, not straight off to the fill, I think. But anyway, you can see we've got a really nice result now. Got that little bit of crack in there and a luster that's very comparable with it. And you can see when you fit that into the mouth, it looks seamless. So very, very happy patient. So the next thing I really wanted to do was realize my vision and learn how to place implants and use those, and also learn how to restore implants as well. So I'm going to touch on restoring implants first. So with CEREC, you can do both screw retained and cement retained restorations. So what you need for doing it, obviously you need to scan the implant in. So you need, on the picture on the right hand side, on the top left part, you can see there's a metal component there in the middle. That's called a tie base. That fits into the implant. You screw it in with the screw on the left, and then you put that white hat just on top of it. And then you can scan, and it picks up where that implant is in 3 dimensions. So you've got buccolingual, mesiodistal, and height. But also the triangle on the top of that hat allows you to see where the timing is. So exactly what you would need to pick up from an analog impression. Okay. On the right hand side are blocks which are specific for implants. They're called meso blocks, and that hole in the middle has been specifically engineered so that it fits very intimately around that tie base. And there's a little like lug on one side, so it can't rotate, it'll just go in one. And so what you can see at the bottom is a cement retained restoration. So what they've done is they've scanned using the tie base, and then once it's milled a restoration, you bond that abutment. So that's an abutment that's going to be bonded to the tie base. You would then screw that in, and then you would bond your crown home on top of it. So that's the crown there. If you decided that you wanted to do a screw retained restoration, instead of having 2 separate pieces there, you would just have one. And that would be a full contour, and it would have a hole in the middle, and then you would just fill it with PTFE and composite in a similar way. So it's a really nice, elegant workflow actually. I like it a lot. And there's a bit to learn, a bit of a learning curve just in terms of tissue handling and the like. But once you get it right, it's very, very nice. Finally, I was able to learn how to place my implants as well. Last bit is about CEREC Guide. So I want to talk you through these guides that we make to allow you to inform the position of your implant placement. So this is the full workflow for implantology. We start on the top left. You can see that you would scan a patient in lieu of an impression. Okay, then you would plan, and in terms of planning, what we want to do is you want a CEREC scan, so you can see teeth and soft tissue, and then you want a CT scan. And the CT scan shows you teeth and bone. And because the teeth are the fixed reference points, you're able to merge the two. So now you have a scan which not only shows you soft tissue, bone, and tooth, but on the CEREC scan, where the tooth is missing. So normally you would scan, and let's say you've prepped a tooth, it's the 6. You would scan and say, right, CEREC, design me a 6 crown to go on prep. But here you've got a missing tooth 6, haven't you? Because that's where the gap is, the implant's going in. but you can still ask CEREC to design you a crown. And what that crown is basically your digital wax up. So it's given you the information about exactly how that tooth should be, and you can manipulate that, of course. And what that does then is it gets transferred into, so there's a picture there showing a blue tooth with brownie jaw, and the blue tooth is that's your digital wax up. So that's been put onto your CT scan now. And what that digital wax up does is it allows you to virtually place your implant in the best possible position to support that restoration. So this is proper crown down, prosthetically driven treatment plan, which is how it should be. And if you think about the RSAFE that you sometimes have doing in the analog fashions, impressions, send to the lab, wax up, come back, thank you very much, I'll have a radiopaque tooth, put it in the patient's mouth, CT with a radiopaque tooth, and then you can virtually place your implant, then get a guide suck down made, which doesn't fit and is useless anyway. And it just is, this is a very elegant and quick and simple way of doing it. Once you virtually place your implant, then what we can do is export that information back into CEREC, and you can fabricate a guide, which you can either have done third party, you can get a lab to do it, or you can mill that CEREC guide in the CEREC milling unit. And it doesn't cost very much, it's like 30, 40 quid. So I guide every single one of my implants. I mean, it's silly not to, because the amount of time it saves me in surgery is just a joke. So I more than make up that 30 quid that I'm paying for the blocks. So once I've got the guide, that is now forcing me to place the implant in the correct place, normally for screw access. I like screw retain, I've got a leaning towards that. So we place the implant, and then once we've placed the implant, it's integrated, we come back down the slope, and we can use CEREC again with a tie base that I showed you before with a little hat. You can scan that and then use that to mill your mesoblock restoration with a hole in it, and then you can construct all of the restoration that goes in. So it's a completely model-less workflow. It's beautiful, honestly, it's really, really, really nice. So this is the 3D view that I was talking about. So you can see at the upper is the CEREC scan of the patient, and that's been merged with the CT. You can see the patient had missing 6 and 5. And what I've done there is I've made a wax up to tell me the perfect position or the ideal position for the restorations. And if I take that model away, that's all I've done. I've just taken that sandy model away there. Then you can see how that's informed my choice of implant size. Obviously, that's not just because of restoration, that would be to do with bone and all the rest of it. So it gives me a really good idea about when I can and when I shouldn't have screw retain access. I think, I know that there are some people who prefer just screw retained at all expense, but I think we should consider where the bone is as well, and not graft always if we don't have to. I think there's nicer ways of doing things. But anyway, that's my personal opinion. But this is now going to allow me to make 2 guides. Now, the limitation with the CEREC is it will only make a guide for a single implant. So that's why in this case you see 2 separate guides. Since I'm in this case, now if I have multiple implants, I'd rather send it away to CICAP. That's what I normally use. And what they have there is a facility to mill guides which allow you to have multiple implants in. And it's just easier. I know it costs a bit more, maybe like 200 quid or whatever. But I feel like the amount of time it saves me is worth it, especially in a case where it's 2 implants. I mean, there's quite a bit of profit in that one because the placement is very, very quick. So what we do first, we try the guide in. I know I've already cut the flap there, you can see in the photo, but I promise I will have tried the guide in before. But generally they fit really nicely, but it's a pain in the arse. If you've got to adjust that and the flap's already open, it's a bad day. Okay, now, some people think that guided surgery is synonymous with flapless surgery, and it's not. Okay, there are some very, very specific requirements for being able to do flapless surgery in a predictable way. And this is a chap from Harvard, Herman Gallucci, and he presented these guidelines. So the first most important thing is that you need to have adequate keratinized gingiva. Obviously, you want keratinized gingiva all the way around that implant for longevity, for them to be able to brush without it hurting, and maintenance and all the like afterwards. So if you have very little keratinized gingiva and then you stick a tissue punch in it and throw it in the bin, then you've probably lost all of the cracked tissue. So not a good idea. If you've got a thin band of cracked tissue, you're better off making a nice clean incision midway through, moving that out and then suturing it back lightly so that you have some denuded bone in the middle, and then you will get more cracked tissue afterwards. So that's just good surgery. It does need to be guided surgery, okay? There's none of this like just drill and hope kind of thing. You need at least the primary osteotomy to be, or pilot drill to be guided so that you've got an idea about height and angulation and the like. It would be very good to have an adequate safety margin as well. And what I mean by that is that there are errors even in a guided workflow, just like there are brain guided, which is what is called when it's not computer guided. There are obviously errors there, but there are also errors when you're doing guided surgery as well. So if, let's say, you are 0.5 millimeter away from a vital structure, my advice would be not to go flapless, raise a flap, so that you're also able to use the bone as a reference point, as a second sort of line of defense, if you like. Make sure you're in the right place. And then the last one, you need to have adequate bone, because if you're grafting for any reason, then obviously you need a flap to be able to access the bone. That's basic. So you can see that I've just opened the flap. This is back when I was super shit. So please excuse the photos if they're terrible and procedure, but this is one of my first implants, certainly my first guided implant case. So what you need is what's called a drill key. What you can probably see there, so it's a long handle, and on the right hand side of the picture, take my word for it, there's a cylinder. The outer ring of the cylinder will fit very intimately into your plastic CEREC guide, and the internal diameter that you see there is for your pilot drill. So this is a pilot guided workflow. Okay, I like pilot guided. I prefer pilot guided because it's a bit cumbersome using the guide for the whole of the surgery. And what you find with the pilot is that you've done the hard work. Yeah, you've got your position, which is really tough. And if I may say, like, I hate doing 6 and 5 together unless I'm guided, because the 6 is a bit bigger than the 5, and it's difficult to know exactly where to start the osteotomy. Or at least that's my challenge sometimes. So I really like to just guide it because it's going to tell me where to go. And then once I know where I'm going, it gives me the positioning. So buccolingually angulation means your distal angulation and height as well. So once I've done my pilot drill, I'm done. The next ones are just there to just gently follow that hole, and you use your endo hand, your endo tactile feedback, and you allow the osteotomy to guide your next drill and the next one, and generally you should be on target. So you can see there the drill key in place in the guide, and you can see that's both of them there. And then we drill our pilot holes, obviously guided. So we know that the guide is down firmly. We check and check and check, and we make sure that it's informing our position properly. Okay. Now, once you've got those pilot holes, you are mostly there. Now, I really love this photo. This is the other challenge that you find when you're doing implant surgery. You raise the flap, and you have to understand that you're often looking at the saddle or the ridge in the same way that this photograph is. So the photo is obviously looking from a very skewed angle, which is basically the operator angle. So I get out of the way, and then my nurse came in and took the snap, because I thought that would be a nice way for everybody to see the procedure. And can you see how close that 5 osteotomy looks to the 4? So that's not because it's too close, it's because your brain tricks you, because there's a shadow of bone behind the 4, just distal to the 4, that you can't see. So it's this kind of perception of the width of the ridge, the position of where you think those osteotomies should be, because of the angle in which you're looking at everything, that sometimes creates the problems. Well, certainly it does for me. Yeah, it does for me. And so I love to do guided because it just helps me to sidestep that. It really does. So all you're doing after that is freehand now, as mentioned, just enlarging those osteotomies. And then you can place the implants in, and you can do that guided or not. I mean, in my workflow, I don't do that guided. Okay, suture it all up nicely, and that's your final result. So happy days. And what's next? As we touched on before, We can go from single tooth dentistry to full mouth and getting confidence to do full mouth because you know that stuff just fits. It's brilliant. It's amazing. And if it doesn't fit, just mill it again. It's okay. It's not the worst day in the office. We have CEREC ortho at the practice. Well, I don't do ortho myself, or my associate Josh. He's very, very good at ortho. So we don't take impressions for patients anymore. We scan them. And we're in the process of delegating scanning out so that others are able to do it. And that seems to work really, really well. It's a nice way of doing it. And when you send a CEREC scan or whichever scan to Invisalign, you always get the clincher prep much quicker as well. And I'm loving CEREC Connect because, as you saw with the single central case, however accurate I was, I would really have to struggle. I would really have to struggle to get as nice a result as the technician got for me. So using them in the right cases is brilliant. And honestly, CEREC has been the single biggest thing that has improved my dentistry and my practice. And it's turned, I was like a normal dentist, I know, that sounds a bit cocky, doesn't it, into an outstanding dentist. But outstanding in the sense that I'm someone that people look to learn and for teaching and as a guide for how they can do well, they can do better. So please don't miss out on this, this tool that allows you to get to that next level and improve the standard that your patients will get. Just wanted to let you know about a course that I'm involved in as well. So this is the postgraduate certificate in Manchester. So ICE is the beautiful facility in Manchester that Professor Jamal Usa is the head of. Fantastic implant surgeon, and he's been using CEREC for implants loads and loads, but also other facets of digital dentistry as well. They very kindly asked me to come along and speak. I do a day on digital dentistry there, and you can see there are some esteemed speakers there. Julian Kaplan, the godfather of CEREC in the UK. Simon Chard as well. He's again amazingly talented dentist. He's younger than me as well, so I hate him lots and lots. But no, he's a lovely guy, really lovely guy. And then Sinead, beautiful Sinead, who does a fantastic work with CEREC, both implant and restorative as well. There's some guy called Alif Moosajee, I'm not sure if he's any good. But yeah, brilliant faculty, brilliant facility as well. So yeah, I can't recommend it highly enough. And a big thank you. That's the Smiling Dentist, I said. So all of the proceeds go to charity. So I'm proud of it. I think it's, I wanted to do some good outside of what happened in the surgery. So I'm happy that we were able to do something like this. Thank you very much for your attention. And I wonder, do we have any questions? Oh, Helen, hello, how are you? How deep should the margin be when preparing for ceramic crown made in CEREC? So what I found early on, and this was even before I was getting beautiful aesthetics with the restorations themselves, was that the way that the margin could blend so the restoration tooth interface would almost become invisible when it's bonded with the right shade of cement and all the rest. And as a result, I try, if I'm able to keep my margin super gingival because I know they will hide, be hidden. So obviously that allows me then to do easier dentistry, okay, because there's no retraction cord or anything like that. It allows me to have much easier checkups because it's visual checkup rather than having to probe subgingivally to know if things are right. But most importantly, it allows my patients to clean almost effortlessly. You know, it's almost self-cleansing. So I really like being able to have confidence to have super gingival margins. Now, obviously, the allegory to that is if you have a restoration, you've got to follow it. Ideally, you want to be on a sound tooth structure. So if that means you've got to go a little bit subgingival, then it's similar management of the soft tissue as it would be for an analog impression, whether it be retraction cord, maybe black or bright white retraction cord, like PTFE, you can PTFE. The reason I mention that is because if you can pack it so it's sub-margin, so you can see the whole margin on the CEREC scan, then you don't have to remove the cord and then do your scan, because then it starts bleeding and all the rest of it. What you can do instead, leave it there, scan, and then you get a nice color mismatch, if you like, between where the margin is tooth colored and wherever your retraction cord is. So that's a really nice tip as well. Very, very deep margins. I don't do it much myself, but you can obviously do deep margin elevation as well. So that's the process of bonding more predictably composite to the very, very deep margin, and then prepping, bringing your prep perhaps supragingival, and then doing like a sandwich where you would then place your crown and bond that to the composite. I hope that helps. Emma, how did I finance going digital? Ooh, that's a good question. So what I did was I jumped in, and then I decided that I wanted to know how much it would be from month to month. Now, they don't do this anymore, which is really good. I'm happy about this. Once upon a time, Henry Schein and all the companies would say, look, it's going to cost you X amount a month. And I think it's like £1,600, £1,700 a month, whatever. That's just the deal I'm on, yeah? And for that, you only need to do 3-4 crowns and you've made your money back. Bullshit, yeah? You're going to do those 3 or 4 crowns anyway. That's not how you make your money. How you make your money, really, and I mean it, you do, is the fact that, one, you will save on lab bill, okay? But let's say if your each Emax crown is 125, 150, you just divide up however many you need to make every month to make sure that's your minimum. But remember what I said earlier about patients will have crowns when before they would have said, no, patch it up, I can't tolerate impressions. No, patch it up, I can't come and see you twice. So these are patients that then you have additional revenue from because they're going for crown, whereas before it would have just been plus. So this is very nice because really you're offering your patient the right treatment. And that's how I feel about it. I'm not inventing CEREC treatment for myself because I've got something that I need to finance. It's not like that. It's about knowing what I can achieve with CEREC, how good it is, and feeling confident in everything I say to a patient. And I don't know if you guys have found this, but sometimes if you're saying something, you're paying lip service, but you don't really believe it in your heart because you had a bad experience about providing, like this bridge I was telling you guys about. Oh, bloody hell, I'm going to do another bridge for ages. I'm going to tell them to have an implant instead of a bridge. So I don't want that bloody experience again. So, I mean, that's interesting. So you will always congruently come across and recommend options that you believe are the best for the patient because you know you can predictably provide them without our sake. You're not going to be embarrassed because in a year it's failed. You know what you do that works for your patients. So you will realize that that will happen a lot with CEREC as well. Lovely. Do you have any advice for anyone thinking of starting their digital journey? Emma, lovely question. Yes, I do. I think that what you probably want to do is go on as many courses about digital dentistry as you can, as practicable obviously, and get a feel for the different scanners, how they scan, what they can do, what they can't do. Okay. Once you've decided, you'll get a gut feeling about which one you think is best. Okay, and then go with it, because you can get analysis paralysis as well, where you'll think, oh, then there's an update's going to come out for this one, and then an update and that, and all the rest of it. Once you've decided which one you're going to go for, just go for it. Just take the plunge, do it. And then commit yourself to learning all you can about that one and forget about the other ones. Just forget about it, because it's not, they'll all be able to do a really worthwhile service for you. Now, I know I am biased to CEREC. I know CEREC is also more expensive than some of the other ones. The other ones are great as well for scanning. But what I like about CEREC in my practice is it's the best package for providing same-day dentistry, because it's got an acquisition unit with software inbuilt that designs the crowns and then also transfers that amazing information to a milling unit that it knows it talks to well. It's a very established workflow. It's education all around that package. It's great. So I feel like I've got a lot from my investment. So I'm really happy I did it. And it's not cheap. I know it's not. But That's value, isn't it? Like if you're asking your patient to spend 30 grand on a treatment plan for a full mouth rehab, you've got to believe that they are getting 50 grams value from it. Yeah, that's how much you know it will change their life. And it's an easy sell because you know you can deliver on that as well. If you don't believe in your own product, then you may as well not bother. That's my opinion. And what made me go digital? That's also a great question. So for me, as I mentioned, it was really that push for trying to do implants in a guided way and knowing that having a digital platform would allow me to do that best. I also had influence from some of my mentors, people I respected, who had also done a similar thing. They'd invested in CEREC or invested in other digital scanners, and I could see the benefits. So that's a really important point as well. Sometimes, you know, the thing about evidence-based dentistry is you can find evidence to support any argument. In my experience, I think if you can find somebody who is doing what you would like to do, getting the results that you would like to get, then you need to soak up very quickly what they're doing and copy them, yeah, or model them. Yeah, that's the other term, model them. And in doing so, success leaves clues. So if you do everything that a successful person does, yes, however you define success, then you will find that you will get the same results that they get. Okay, if you apply yourself to doing it, it's a formula. There's a science behind it. So that's a really important thing. So have a look around at people who are getting the results you want and see what they're doing. And if they have gone digital as well, then there's probably a clue there that helps you to make that decision. Right, I don't think there are any more questions. So in the absence of any more, I want to say thank you very much for listening to me ramble on. I'm not very well today, by the way. I woke up, I feel like crap. But I hope it wasn't too bad. I hope I had a little bit of energy and vibe. And hopefully you'll take on board what we discussed today and at least look into it. I'd be delighted if you did. Thank you very much.